Hi, I'm Kevin Killian. I'm one of the PGY3s over at Henry Ford Allegiance. I had an interesting case of a drug-induced SIADH secondary to paliperidone, also known as Invega, resulting in seizures. My attending was Dr. Amy Blazin, and this case occurred at the Sparrow Pediatric ED. Patient was brought in via EMS. Our report was a 15-year-old male, very large, 200 pounds, with a history of autism spectrum disorder and self-harm behaviors, including headbanging. He came in after two witnessed tonic-clonic seizures. One seizure was witnessed by parents lasting approximately 5 minutes with tongue biting and urinary incontinence. It resolved spontaneously, and he was postictal for a short period of time and returned back to his baseline. Another tonic-clonic seizure was witnessed by EMS in the rig, and they gave him 10 milligrams of Versed to stop the seizure. Lasted about 3 minutes. Parents noted that there's no new significant headbanging episodes or injuries in the last 48 hours. He hadn't really had any obvious behavioral changes, and he did have two new medications, Visceral and Invega. He had some increased sweating and swaying with walking, but they assumed it was due to the medications. He also was on clonidine and trileptal. With his presentation and no history of seizures, we were initially concerned about trauma. He was sent to the CT scanner after a stat lab panel was ordered. On exam, he did have some lateral tongue biting, some significant hematomas along the entire head, and he had some listing eye movements related to his sedation. Otherwise, he was moving all four extremities, seemed extremely sluggish due to the Versed, but otherwise non-focal neurological exam. While he was at CAT scan, getting images, his sodium came back at 115. When he came back from the CT scanner, besides his cephalohematomas, no intracranial abnormalities. We started treatment with 3% hypertonic according to the ICU and neurology consults that we received. Stopped all of the possible medications that could be causing issues, including his Invega and his trileptal. He also was to receive an MRI and MRV, but would have to be sedated due to his behavioral issues. While in the ICU, he also became hypertensive, tachycardic, and febrile, and they noticed his liver enzymes were elevated. Once his electrolytes had improved, he had improvement of his vitals. Low suspicion for NMS at that time with that series of symptoms. When he was back to his baseline, didn't have any more seizures. His sodium was pretty normal. They monitored his behaviors to make sure there was no psychogenic aspect to this. Did not have any issues there. Was discharged. He came back about 10 days later with a similar presentation, but no seizures, kind of listing with ataxic gait and some gaze deviation. Turned out at that time, mother was very in tune to what was going on, said, yep, he's been drinking water like crazy. So at that time, it was more of a psychogenic polydipsia. He did undergo MRIs in the hospital at that time. And besides the cephalohematomas, nothing intracranially. So from all the information we were able to gather through his two stays, it looks like his first episode with his seizures and hyponatremia was most likely related to the Invega medication that he was started on. There are multiple case studies talking about how the second generation antipsychotics can lead to SIADH, and that would make sense for Invega to cause this issue because it is a metabolite of risperidone. The main concern we have, especially with the seizures and the SIADH, in this case, is Invega has depot injections anywhere from 1 month to 3 months. So definitely needs more research as to the incidence of SIADH and the long-term effects of that, especially if you're starting someone on those long-acting formulations. Of note, this case is in particularly interesting because most of the case studies are based on large single doses for acute psychosis administration of Invega, whereas this case, it was an oral medication that was helping with his agitation behaviors. That's my case. Please read my poster for more information, and thank you very much.